triage board for our shift today. First, we'll look at upper GI perforations. Second, bowel obstructions. Third, pediatric emergencies. And finally, trauma and complications.
All right, Section 1. Perforations from the esophagus to the stomach. Here's your first Socratic mystery of the shift. Picture this. You've got a 35-year-old patient with a history of alcoholism. He comes in with sudden, severe chest pain right after a really violent bout of retching and vomiting. You listen to his heart with your stethoscope, and you hear this bizarre crunching sound. So what's your diagnosis? Did you guess it? The answer is Boerhaave syndrome. That crunching sound? That is the massive keyword here. It's called Hammond's sign. Boerhaave syndrome is a spontaneous perforation of the esophagus, usually down in the lower third, and it's caused by that severe vomiting. The classic triad you're looking for includes retching, chest pain, and subcutaneous emphysema. That emphysema is just air trapped under the tissues, and it's exactly what creates that unmistakable crunching noise right over the heart. Now, to confirm that esophageal leak, we absolutely have to follow the ER's golden rule. Patient stability dictates your imaging. If the patient has stable vitals, your go-to investigation is a contrast-enhanced CT scan. But, and this is a big but, if their vitals are unstable, like a dropping blood pressure or a crazy high heart rate, you skip the CT completely. No way do they go in that scanner. Instead, you do a quick X-ray or a simple contrast study right there on the spot. Once that perforation is confirmed, whether it's Boerhaave's, maybe a post-endoscopy injury, or a peptic ulcer from way too many painkillers, we immediately trigger a standardized 4-step baseline management protocol. Step 1, NPO, nil per oral, absolutely nothing by mouth. Step 2, aggressive IV hydration, because these patients are seriously dehydrated. Step 3, IV antibiotics to fend off impending sepsis. And Step 4, we rush them to the OR for surgery, like doing an omental Graham's patch repair for an ulcer.
Moving right along, Section 2, bowel obstructions and blockages. Ready for your next clinical mystery? A patient arrives with massive abdominal distension, and they tell you they haven't passed flatus or feces for a whole day. You take a listen and hear hyperperistaltic bowel sounds. Basically, the intestines are aggressively trying to push past a blockade. But here's the massive keyword in their history. They had an appendectomy 2 years ago. What's causing the blockage? The diagnosis here is an adhesive bowel obstruction. Honestly, any time a patient has had previous abdominal surgery, even if it was years and years ago, and they present with a blockage, adhesions have to be your primary suspect. They're actually the most common cause of bowel obstruction overall. But here's what makes this so fascinating. It's the only dynamic obstruction where our first line of action is just to wait. We use conservative management, NPO, IV fluids, and NG tube, and we hold off for 48 to 72 hours. Why? Because the majority resolve on their own. And paradoxically, cutting them open to operate again would just cause even more adhesions down the road. When we're hunting for blockages, there are some incredibly cool visual buzzwords to watch out for. See multiple air fluid levels on an upright X-ray? Boom, bowel obstruction. Gas under the diaphragm? That's a hollow viscous perforation. But my absolute favorite has to be the coffee bean sign. This points straight to a sigmoid volvulus, which is a twisted bowel, often seen in young male patients taking antipsychotic meds for bipolar disorder. The source actually shares a hilarious, if slightly grim, anecdote about treating this. Since colonoscopic decompression is the standard, when a scope isn't handy, some unlucky intern gets banished to an isolated room to insert a flatus tube. The result? A sudden, room-clearing rush of trapped gas and feces that instantly decompresses that twisted bowel. What a shift, right? Okay, let's switch gears. Section 3, Pediatric Abdominal Emergencies. Let's set the scene. An anxious mother brings in her 2-year-old boy. He is crying inconsolably. He hasn't passed normal stool, but he did have an episode of vomiting and, most alarmingly, bleeding from the rectum. You assess his distended abdomen. What is your immediate clinical suspicion? This is a textbook presentation of intussusception. This is a crazy condition where a segment of the intestine literally folds or telescopes inside of an adjacent segment. Now, because we're dealing with a tiny child, our investigation of choice isn't a CT scan, it's an ultrasound. And this brilliantly shows off the visual power of ultrasound because you'll see a very distinct donut sign or pseudo-kidney sign. But the absolute best part is the treatment. We use a contrast enema. The physical pressure of the contrast flowing in actually pushes that telescoped intestine right back into its proper place. It's like magic, simultaneously diagnostic and therapeutic.
Now, I want you to lock this exact number in your brain. 16. If you've got a firstborn, 3-week-old infant coming in with severe non-bilious vomiting and looking highly dehydrated, your brain should jump to hypertrophic pyloric stenosis. If you feed the baby, you might even feel this little olive-shaped lump in their abdomen. To confirm it with an ultrasound, you look at the pyloric channel. If the length is greater than 16 millimeters and the muscle thickness is over 4 millimeters, you've nailed the diagnosis. From there, you correct their very unique metabolic imbalance with fluids and then perform a Romsted's pyloromyotomy.
All right, deep breath. Section 4, trauma and surgical complications.
You are called down to a high-stress trauma scenario. A 20-year-old arrives with a gunshot wound to the abdomen. His dressing is already soaked with bile. His blood pressure is tanking, meaning his vitals are incredibly unstable. You do a quick bedside fast scan. That's a focused assessment with sonography for trauma. And it comes back positive for fluid collection in the pelvis. What is your immediate next step? Your immediate step? An exploratory laparotomy. You bypass everything else and rush that patient straight to the operating theater. Remember our golden rule from earlier. Unstable vitals mean you completely skip the CT scan. Period. That bile leak already confirms a perforation anyway. Once you're inside, if you find multiple perforations close together in the small intestine, you can resect and reconnect them. But if that gunshot damaged the colon, say the sigmoid colon, in a highly contaminated environment, you have to pivot to damage control. You perform a Hartmann's procedure, rerouting the bowel to a colostomy bag. It saves the patient's life and avoids a highly infected repair. Now let's look at a post-op situation. It's day 3 after a major abdominal surgery. The surgical resident is pacing the halls, intensely anxious because the patient hasn't passed flatus. Seriously, in the surgical wards, the sound of passing gas is literally music to a resident's ears. The patient's vitals are perfectly stable, but the abdomen is completely silent. Absolutely no bowel sounds when you put your stethoscope to it. So what's going on? That terrifying silence is known as paralytic ileus. Basically, the bowels have just gone to sleep after the massive trauma of surgery. But the key word to remember here is that this is often just a temporary metabolic glitch. The most common culprit? Hypokalemia, low potassium. It's wild, but simply correcting that patient's potassium levels or checking their kidney functions can wake the bowel right back up. For our last case, let's say a patient just had their gallbladder removed, but 2 days later, they're back with right upper abdominal pain, a fever, and jaundice. You suspect a post-surgical bile leak. How timing alters your management here is absolutely crucial. If that leak is discovered early, meaning less than 3 days post-op, you can go back in, reoperate, and physically suture the repair. But if it's a late leak, discovered after 3 days, those tissues are way too inflamed. They simply will not hold sutures. It'd be like sewing through wet tissue paper. Instead, you use an endoscopic procedure called an ERCP to place a stent inside, along with a pigtail catheter to drain the fluid, allowing the whole thing to heal safely from the inside out.
And just like that, our fast-paced ER shift comes to an end. We've seen how a single key word, whether it's a weird crunching sound, an old appendectomy scar, or a 16-millimeter measurement on a screen, can literally mean the difference between life and death. The Pandora's box of the abdomen is wide open. So the question is, the next time you are faced with a complex medical mystery, are you ready to spot those key words and unlock the diagnosis yourself?